All right, so picture this. You're sitting in the reading room, or maybe you're sweating through a board exam, and you pull up a case file.
Right.
You've got a 55-year-old man, history of chronic hepatitis B. He's asymptomatic, but surveillance imaging. It picks up this solitary mass in the right lobe of his liver.
It's the classic setup. I mean, you see hepatitis B and liver mass in the same sentence,
Mm-hmm.
and your brain should immediately lock on to a very specific diagnosis before you even see the pictures.
Right, the pre-test probability is just massive. But then you look at the multi-phase CT, and you see that signature behavior. The report says arterial phase hyperenhancement.
Followed by portal venous washout.
Exactly.
And that's pretty much the ballgame. In that specific context, a high-risk patient, that specific vascular pattern, you rarely need anything else. You've got a diagnosis of hepatocellular carcinoma or HCC.
So hold on, let's tweak the variables. Same liver mass, same age. But let's strip away the hepatitis B. Instead, this patient had a sigmoid colon resection 3 years ago for cancer.
Totally different algorithm. Yeah. I mean, completely. Now, that mass probably isn't the liver acting up on its own. It's the liver acting as a landing pad. You're looking at metastasis.
And that distinction is the whole mission for this deep dive. We aren't just memorizing lists of symptoms today. We are really decoding liver masses. We're talking about high-stakes pattern recognition.
It is. It's about distinguishing the liver's own failing cells from, invaders crashing the party.
It's one of the most critical differentials in all of oncology.
And honestly, it's a masterclass in hemodynamics.
Yeah.
If you understand how blood flows through the liver, you really understand these tumors. You don't need to just memorize the rules. The biology tells you the rules.
That's what we're going to unpack. We'll break it down into 4 pillars. The background soil, or the disease state, the vascular patterns on imaging, which is where the magic happens.
Oh, absolutely.
The tumor markers, and then finally the decision-making, when to cut, when to transplant, and the famous Long criteria.
But let's start with that soil concept.
Hmm.
Because context is, well, it's everything here.
We mentioned the 55-year-old with Hep B, but usually HCC doesn't just appear in a perfectly healthy liver, does it? It's a disease of degeneration.
Correct. The overwhelming majority of HCC cases arise in the background of cirrhosis. The liver has been beaten up for years, whether by alcohol, fatty liver disease, viruses, and that constant cycle of damage and repair, it eventually leads to mutations.
So if you see a shrunken nodular cirrhotic liver on a scan and you spot a new mass.
It is HCC until proven otherwise. The odds are just overwhelmingly in its favor.
But there's a trap here, right? A really big exception that examiners and, biology love to throw at us.
The hepatitis B exceptions. This is so crucial. While, say, hepatitis C and alcohol almost always need to cause cirrhosis before they cause cancer, hepatitis B is different. The virus itself is directly oncogenic. It actually integrates into the host DNA.
So you can have a patient with a relatively healthy-looking liver, texture-wise, no cirrhosis, no major scarring, but just because they are Hep B positive, they can still pop a primary HCC.
Exactly. You can't rely on the presence of cirrhosis to screen for HCC in the Hep B population. And that's why the surveillance guidelines are so strict for them.
Okay, let's get into the mechanics of the imaging. This is the part that I think confuses people, but it's actually just plumbing. We said arterial enhancement and washout. Walk us through the why of that.
To get the imaging, you have to get the liver's unique dual blood supply. A normal, healthy liver gets, about 75% of its blood from the portal vein.
Right, the nutrient-rich blood coming from the gut.
That's it. And only about 25% from the hepatic artery.
So on a CT scan, when you inject contrast, the normal liver tissue doesn't light up right away because it's waiting for that slow venous blood from the portal system.
Precisely. The background liver is relatively dark in that early arterial phase. But HCC is a tumor of chaos. As it grows, it recruits new blood vessels. But it doesn't recruit from the portal vein. It recruits almost exclusively from the hepatic artery.
Ah, so it creates its own high-pressure arterial feed directly into the tumor.
Right. So seconds after you inject the contrast dye, the arteries fill up. The tumor, feeding off those arteries, just flashes bright white hyperenhancement. Meanwhile, the rest of the liver is still kind of waiting for its delivery from the portal vein.
That's the light bulb moment. But then comes the washout.
And the washout is just the inverse. A minute later, the contrast is moved out of the arteries and is now in the veins. So the normal liver tissue is soaking up all that portal venous contrast, and it looks bright.
That the tumor.
The tumor only has that arterial supply. The contrast has already washed right through it and is gone.
So the tumor goes dark while the background liver goes bright.
And that mismatch, Bright when the liver is dark, dark when the liver is bright. That is the absolute hallmark. If you see that pattern in a cirrhotic liver, you have a diagnosis.
And this leads to something that's almost unique in oncology. I mean, for almost every other cancer, breast, prostate, lung, the mantra is tissue is the issue. You have to biopsy it.
Right.
But here, we play by different rules.
We do. If you have a lesion larger than 1 centimeter in a cirrhotic liver, and it shows that specific arterial enhancement and washout, you do not need a biopsy. The imaging is considered diagnostic.
Which is just wild when you think about it. We're starting chemotherapy or scheduling transplants based purely on a picture.
It really is. And it speaks to how specific that vascular derangement is. In fact, we often avoid biopsy in these cases, not just because we don't need it, but because there's a risk. If you stick a needle into an HCC, there's a small but real chance of seeding the tract.
Dragging cancer cells out along the needle path, spreading the disease.
Exactly. So if the pattern fits, you don't poke the bear.
Okay, so let's compare that to our second patient, the one with the colon cancer history.
The invader. Metastasis.
Right.
And statistically, this is actually the more common scenario. The liver is the most common site for metastatic spread from the GI tract. And again, this is just plumbing.
The portal venous system acts like a funnel.
It does. It drains the colon, the stomach, the pancreas, and it dumps all of that right into the liver for filtration. So if a cancer cell breaks off from a tumor in, say, the sigmoid colon, the liver is the very first capillary bed it's going to hit. It gets stuck and starts to grow.
But these tumors, they don't look like HCC on the scan. They don't have that flash and fade pattern.
No, generally not. They aren't forming that same complex arterial network. Metastases are often hypovascular. On imaging, you more often see a peripheral rim enhancement.
The target sign or that halo effect.
Right. What's happening there is the center of the tumor is outgrowing its own blood supply and becoming necrotic. It dies off. So the center is dark. The outer rim is the active growing edge, so it takes up some contrast, and you get this glowing ring with a dark center.
And unlike HCC, which often starts as a solitary rebel, metastases usually bring friends.
Oh yeah, it's rarely just one. Because it's hematogenous spread, it's coming through the blood, it's like a shower of meteors hitting the liver.
Yeah.
You'll typically see multiple lesions scattered across both lobes.
So if I'm looking at a scan with 12 different lesions, I should be thinking metastasis way before I'm thinking HCC.
Definitely. HCC can be multifocal, but that cannonball appearance of multiple masses usually points to a secondary cause.
Okay, let's talk biomarkers. We've got the pictures. What does the blood tell us? We always hear about AFP.
Alpha-fetoprotein. It's the classic marker for HCC. If you see an AFP level shooting up into the thousands combined with the liver mass, it's virtually diagnostic.
But the absence of AOP doesn't save you.
And that is the key takeaway. A normal AFP does not rule out HCC. Plenty of these hepatocellular carcinomas are non-secretors. But if it is elevated, say over 400, it's a very strong confirmation.
Whereas for our colon cancer patient, AFP would probably be normal.
Right. For them, you're looking at CEA carcinoembryonic antigen, so broad strokes. Rising AFP points to the liver's own cells. Rising CEA points to the gut.
Okay, I want to synthesize this into a kind of logic engine for the listener. We've got these variables, history, imaging, markers. Let's run a few if-then scenarios to really lock this in.
Let's do it.
All right, scenario A. A patient with known cirrhosis. Ultrasound shows a 2-centimeter mass. CT shows arterial glow and venous washout. AFP is 500.
That's a slam dunk HCC. No biopsy needed. You move straight to treatment planning. The combination of the background cirrhosis and that washout pattern is definitive.
Okay. Scenario B. Patient had stage 3 colon cancer 5 years ago. Now, on a routine follow-up, their liver enzymes are a bit bumpy. CT shows 3 hypodense lesions with rim enhancement.
Metastatic disease. The history of colon cancer plus multiple lesions plus that halo look that makes metastasis the primary driver. You check the CEA to confirm, but the imaging is already telling the story.
Scenario C. This is the tricky one. Patient has hepatitis B. No cirrhosis. A single 3-centimeter mass is found. And it washes out.
You have to trust the vascular pattern. Even without the cirrhosis, the Hep B status plus the washout equals HCC. You cannot get hung up on the lack of scarring.
Is there a scenario where the cirrhosis equals HCC logic can fail you?
There is, and it's a nuance that really separates the experts from the novices. A cirrhotic liver is generally bad soil for metastases. It's scarred, The blood flow is all distorted, and it's actually hard for incoming cancer cells to land and grow.
So it's actually rare to see colon metastasis in a cirrhotic liver.
Much less common than in a healthy liver, yes.
Yeah.
So if you see a mass in a cirrhotic liver, the statistical probability that it's a primary HCC is overwhelming. You don't go hunting for a colon primary unless the imaging is completely atypical.
That's a great clinical pearl. Bad soil protects against invasion but promotes internal rebellion.
Precisely.
All right, so we've diagnosed it. We know what we're dealing with. Now we have to fix it. This brings us to the surgical decision-making, which is arguably even more complex.
It is, because the liver is just.
Yeah.
It's an unforgiving organ.
Yeah.
With HCC, you really have two competing problems.
Yeah.
You have the cancer, and you have the cirrhosis.
Right. You can't just cut out the tumor if the rest of the liver is failing.
You can't. If you resect, cut out a wedge of the liver on a patient with advanced cirrhosis, they might go into liver failure and die right on the table. You might get the cancer, but you lose the patient.
So for those patients, we look at transplantation. We take out the whole diseased organ and replace it. But we can't give a new liver to everyone. There just aren't enough organs.
And this brings us to the Milan criteria. This was a landmark development. We needed a way to identify which cancer patients would actually benefit and survive long-term after transplant. If the tumor is too aggressive, it will just recur in the new liver, and we've wasted a precious organ.
So what are the magic numbers?
The Milan criteria are incredibly strict. To qualify, a patient must have a single tumor that is less than or equal to 5 centimeters,
Okay. Or?
or up to 3 separate tumors, provided none of them is larger than 3 centimeters.
So one big one, but not too big, or 3 small ones. Why those specific numbers? Why 5 centimeters and not 6?
It's a proxy for the tumor's biology. The data show that once a tumor gets bigger than 5 centimeters, or once you have more than 3 of them, the likelihood of microvascular invasion,
Microscopic spread into the blood vessels.
it skyrockets. Exactly.
Meaning the cancer is probably already outside the liver, even if you can't see it yet on a scan.
That's it. And if it's already outside the liver, putting in a new one won't cure them. The cancer will just come back. So the Milan criteria isn't just a ruler measurement. It's a biological threshold for curability.
And if you fit the criteria, your survival rate is comparable to someone getting a transplant for non-cancer reasons.
Yes, roughly 70 to 75% survival at 4 years. If you're outside the criteria, those numbers they drop off a cliff.
Okay, now let's pivot back to metastasis. If we have a patient with colon cancer that spread to the liver, do we use Milan? Do we transplant them?
Historically, absolutely not. I mean, if cancer is spread from the colon to the liver, that is by definition stage 4 disease. It's systemic. You don't transplant stage 4 cancer.
Yeah. I sense a but coming.
But the paradigm is shifting just a little for resection. If a patient has a solitary metastasis, just one single spot of colon cancer in the liver, we now know that surgically removing that metastasis can, in some cases, be curative.
So for HCC, we worry about the background liver failing. For metastasis, the background liver is usually healthy, so we can be more aggressive with cutting.
Correct. You can take out 70% of a healthy liver and it'll grow back. So if a patient has what we call oligometastatic disease, very limited spread, the surgeons will go in and resect it.
But if they have that cannonball spread, multiple lesions in both lobes.
Then surgery is usually off the table, at least initially. You treat them with systemic chemotherapy. If the chemo shrinks them down enough, maybe you reconsider surgery, but usually that's a medical management case.
So, to recap the treatment logic, HCC is a balance between treating the tumor and respecting the cirrhosis, often leading to a transplant if they fit Milan.
Right.
And metastasis is all about how much disease burden there is. Resect if it's limited, chemo if it's widespread.
That's the framework.
Wow, this has been a heavy download. Let's do a rapid-fire recall to lock in these key patterns before we close. I'll throw a concept at you. You give me the association.
Ready.
Arterial enhancement plus venous washout.
HCC, that's the vascular signature.
Rim enhancement with a central dark spot.
Metastasis, the target sign of necrosis.
A 6-centimeter single tumor in a cirrhotic patient. Transplant.
No. Fails Milan criteria. It's over 5 centimeters, too risky for recurrence.
Marker for colon cancer spread.
CEA,
Marker for HCC.
AFP. But remember, it can be normal.
Most common tumor in the liver overall.
Metastasis, always think invader first, unless.
Unless there is cirrhosis.
Exactly. Cirrhosis flips the odds right back to HCC.
It's amazing how these patterns really create a map. If you follow the map, the blood flow, the background soil, the markers, you usually arrive at the right destination without needing a scalpel for a biopsy.
That's the beauty of hepatology. It's so logical. But I want to leave the listener with one final caution. We've presented this as a binary choice, HCC or metastasis.
But real life isn't always binary.
Right. Not every liver mass is cancer. You have hemangiomas, adenomas, focal nodular hyperplasia, abscesses.
So how do you stay safe?
You stay safe by being rigorous about the pattern. If it doesn't have that classic washout, don't try to force it into the HCC box. If the patient has a fever, think abscess. The classic signs we talked about today are your anchor, but the clinical context is the rest of the ship.
Context is king. Whether it's that 55-year-old with Hep B or the post-op colon cancer survivor, you have to treat the patient, not just the picture.
Couldn't have said it better myself.
Thanks for diving deep with us today. Hopefully the next time you see a liver mass, it looks a little less like a smudge and a lot more like a story.
Always a pleasure.
We'll see you on the next deep dive.